Okay, welcome everyone. Tonight's webinar, I have a couple of topics that I'm going to be covering tonight. A little bit about, I'll start with the knee and then two recently published literature, which is interesting and I think you will find them useful. And followed by an announcement about a new course that we're starting to offer. I'm making sure.
Can you repeat that, Mohini? An announcement about what?
A new course.
All right.
All right. So
Nice.
Please announce a new course. So we are offering online live ultrasound report writing course because I think this is something lacking after module 2A and 2B between upper and lower and fellowship and mentorship module. There's a big gap. And I think we need to fill that up with something. And module 2A and 2B, we are busy. So it's not possible to spend half a day on report writing. So I think this is going to be a good course. And you don't even need to fly in or travel for this. You can be at least or your clinic or your home or wherever. And but then you need, but this is live course, so it's not pre-recorded course. So it's going to be online live interactive course for same like for live courses where you are there for 8 or 9 hours. You will be on your computer and it's going to be interactive. So there will be a limit to total number of participants registering for it. And it's not just didactic, like, I'm talking the whole 8 hours and you're listening. I'll be presenting and then we will be doing analysis of the image. And we will go through the flow chart and follow the steps, how we analyze the image, how we write it up. And each participant will be presenting their own images. And then for that, you will receive some instructions before you sign, before the course date. Once you register, you will get some reading material, some instructions on how to participate in this course. So here it is. We have a one-day report writing course. I've been trying to get this, schedule for quite some time because I feel that clinical webinars once a month are still not enough because webinars are good for some tips and tricks and maybe present some literature, cover some topics, but I think we need a dedicated at least one day report writing course. So you can contact Tiffany if you are interested in attending this. You can register. And we need you to have at least to be attended all other requirements. So the online material, the online videos, and 2A and 2B, all those have to be, you have to have some experience in scanning, and you should have done some scans. So because we are just launching this, the preference will be for people who are doing it for a longer time, so greater number of scans you've done, and the more scans that you have. So you can contact Tiffany for this. So what do you think about it?
I think that's great.
That's great, right? Yeah, I think too. Yeah, I'm really happy that we finally decided on offering this. And this is really
Yeah, I think that looks great, Mohini. It's going to really help so that we're not sending you a bunch of junk that you have to really look over.
I'm always happy to help, and this is really, I enjoy what I do, and I really enjoy interacting with each and every one of you. And so, you don't have to ever worry about what you send me and all that. But I think this is going to add a lot of value to, and make it like less frustrating for everyone on this journey to get the certification. And it's going to help with RMSK preparation too, because you do get a lot of cases there and you have to analyze. There is so much that I can squeeze in 2A and 2B. So yeah. So yeah, you can flood Tiffany's email, and we don't have everyone attending. I'm going to send this announcement to everyone after we conclude tonight's webinar, so everyone is aware of this new course that we are offering. Okay, all right, on to the cases and tonight's webinar after this announcement. So I'm going to start with few points. Okay, I have like different topics that I'm covering, and they all tie down to analysis. So I'm going to start with some important points that you have to keep in mind when you're analyzing your images or interpreting your images of ultrasound scanning. So when you analyze the report or the scans, you're looking for 5 things there. So first one is you're looking for what kind of ecotexture you see. Let's say you are evaluating a tendon, and that can be any tendon, supraspinatus or patellar tendon. So you're looking for what kind of signal you get. So is it hypoechoic or hyperechoic? So that's ecotexture. You're looking for morphology. So what kind of morphology you are seeing? Is it normal morphology? Is the tendon tapered? Does it have its normal shape or contours that we see, which we expect in a normal tendon? Are there any defects? Number 3, there is any tearing, those that will come under defects or tear. And these can be micro tears, can be significantly larger tears, which can be measured. So if there is micro failure of fibers, that's hard to quantify. So you cannot put the calipers. But if you see a focal region where there are defects, you can easily put the caliper and measure it. Always use color Doppler, so you get the color Doppler information if there is any new angiogenesis or not. Then also remember to do dynamic evaluation. So you have to always see structure dynamically, how they are functioning. Like you do your physical examination, you you're not only looking at the patient and using your palpation, you also move them in. You use active and passive movements in your physical examination. So ultrasound is extension of physical examination. So you don't forget to use dynamic evaluation with active or passive movements. So this is what we're looking at. So whenever you look at an image, these are the things we are noting. So when we report, when you write an impression or finding, you say about the signal. So is it hypo or hyper? You say whether the tendon is larger or thinner, or you can say per size thicker or thinner, whichever structure you're evaluating or examining. You talk about the structure in terms of the echo signal, in terms of how that structure appears, its morphology, if there are any defects in that structure, what kind of physiological information you get from color Doppler, right? And then you can sometimes these 4 points may not be enough or may not help you differentiate something. You can always use real-time dynamic evaluation. That's the beauty of ultrasound. You can always add dynamic real-time motion, and that helps a lot, especially those small tears which you cannot evaluate. And actually, I would also put sonopalpation with this, compression with the probe. That is also something you can do dynamically with the ultrasound, as opposed to other imaging modalities. Now, other than those points, you always have to remember, no matter how good of an image you have, if you have only one plane of view, you have incomplete information. And sometimes you think you have 2 plane of view, but you may not, because let's say patellar tendon is long, right? And you are taking a long axis view, where you see the entire tendon from tibial tuberosity, from patellar insertion to tibial tuberosity. But then you have short axis view, which may be right in the middle of the tendon, but your problem is more towards the attachment. So the second plane of view should also be at the level where you see the problem. So let's say you have a tendon and you found a problem at the insertional site, but your short axis view is not at the insertion site, somewhere along proximal or distal to that. sorry, there's no distal after insertion, somewhere proximal to that. So that second plane of view does not serve any purpose here. I mean, it doesn't help you answer the question. So you need to have the second plane exactly at the level where you find the problem. If everything is normal, then it doesn't matter much whether your second plane of view is right in the middle of the tendon or towards the insertion. But there's always, the assumption is that whenever you're scanning, you're always scanning the tendon or the structure that you're scanning along its length and uh, also going medial to lateral. So you're checking the width of the structure and length of the structure. So you get your best images, but you have to evaluate the entire structure. And then you have to also be clinically relevant. And sometimes, patients present with vague symptoms and you don't know which structure is responsible for that. And I'll give you an example of, let's say, elbow. Now, patient has all the symptoms on the medial aspect, and you also have some vague pain anteriorly. So you can do a complete examination of elbow, but you have to pay extra attention to anterior and medial aspect. And try to narrow it down by your palpation skills or your physical exam and other finding, history, maybe what was the mechanism of injury if there was, and you try to find a relevance and narrow it down, and you have to take more images of that anterior and medial aspect. And so that'll be your focus in that complete study. So always make it relevant. And when you have the clinical relevance in your exam, you found the problem. You found the problem at the medial epicondyle. Maybe there was a common flexor origin pathology, like golfer's elbow, and you also found something in the some minor finding, let's say posteriorly. When you report your findings and impression, your impression will start with your medial findings, because that's the most significant and relevant finding. So you may have like 10 different findings, but the least significant or least clinical relevant first. So the first finding or impression is always the most clinically relevant to the patient, why the patient is listening to you, why you're scanning. So that finding has to be reported number one. That has to be the first finding in the report. Okay, so now I'm going to look at some images of the lateral side. So lateral knee, and because I'm seeing a lot of people doing knee imaging, and you're imaging lateral ligament and lateral meniscus, but you're missing one structure. So here is lateral knee LCL. So that's a ligament here. You can see it's wavy, and here it goes to fibula. So bony landmarks are very important here. So that's fibula, this is tibia, and that's femur here, and that's the groove. What groove is that? That's femur, and that's a groove. Come on. Somebody answer. On the lateral aspect, the groove on the femur, what sits there? Okay, someone has to answer that.
Fibula head.
Was that? I can be saying something, but I cannot hear. Someone, come on, this is lateral aspect of the knee. Okay, this is femur. This is fibula, and this is tibia. And of course, now I stitched 3 images to show the continuity. So there's a little, like a little step off that you see here. But this is tibia, this is femur, and that's fibula. That's where the LCL attaches, right? And so what is this groove on the femur?
Trochlear.
What's that?
Trochlear.
Trochlear. You mean femoral trochlea?
Yeah,
And
I know it's not lateral.
so this is lateral, and this is a groove for the popliteus tendons, and this is popliteus tendon here, right? But who's that? Who answered the question?
Oh, that I answered? It's Dick.
Who's
But
that?
I didn't know
It's
what
Dick.
groove.
Oh, it's Dick. Oh, hi, Dick.
I didn't know what groove you were asking for. I've never heard of it as a popliteus groove.
Yeah, that's where the popliteus tendon sits.
So is it called the popliteal groove?
Popliteus tendon. Yeah.
No,
But what
you
is
were
the
asking
groove
us
called?
what groove. You asked us what groove that was laterally.
Yeah, it's on the lateral. This is lateral knee. So yeah, that's on the lateral side, but the popliteus tendon groove, that's where the popliteus tendon sits.
I've never heard it called that.
Okay.
I
We do cover that in module 2B. Okay.
Not when I went through it.
Okay. Okay, now you know it. So let's focus on LCL right now. So this is LCL, right? This is
Yep.
femoral attachment. This is LCL. Here, 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 and here. And why is it dark here? What artifacts?
Fluid collection.
What's that?
Is fluid collection there?
No, no fluid. This is normal knee. This is normal knee.
Could be a little bit of a lobe artifact.
What?
Could it be a little bit of a lobe artifact?
You're close. Yeah, the principle is same, but this is because of anisotropy. Because see, the ligament is going down this way, and your beam is not hitting it at 90 degrees. So this is a refraction artifact. Okay, so there is nothing wrong with this ligament here. This is a normal knee. Now LCL, you may not see it as a straight, stretched out ligament because there are a lot of expansions going medial and lateral. Is attached to other expansions, and I'm going to show you that in the next few slides. Another reason why you see this dark area close to the fibular attachment is biceps femoris just overlies it. Biceps femoris and LCL have common attachment at fibula, right? So it's right overlying the LCL. So superficial to LCL is biceps femoris. So it's going posteriorly. So part of the shadow is biceps femoris going in a different oblique direction, and the part of it is because the LCL is going down like this, down slope. So this is a refraction artifact. So that's one structure that you see on the lateral side. Now the next one is this lateral meniscus. That's the lateral meniscus here. This is again femur, and you can see this groove where the popliteus tendon sits.
Getcha.
Tibia. There's no fibula in the view right now because we're trying to focus here on the meniscus. So sometimes you know that you have to have, although all the structures on the lateral side, you can only focus on one. So the previous image was focused on LCL. This image is focused on lateral meniscus. Again, this groove is the groove where the popliteus tendon sits. And here is the popliteus tendon in the view right now. So you can see, so you don't see the meniscus well here, but you can see part of the LCL here overlying. Can you see the LCL, the band? Fibrillar band that's running on top. Yes?
Yes.
That's
Yes.
LC1. Now this is femur, and that's the groove, and this is popliteus tendon sitting right here. Okay? And so this is the short axis view of popliteus tendon. You can rotate your probe so you are long axis on this tendon. Here is popliteus in long axis. And this is LCL in short axis view. So like, you know, it's like approximately 90 degrees arrangement. So one is going, so this is going obliquely under the LCL. So if you're long on LCL, you're short, oblique short on popliteus. When you're long on popliteus, you are short on LCL. Makes sense? Vice versa, like opposite relationship. Now let's look at the anatomy of this area. So this is the popliteus tendon. Coming posteriorly, the muscle is posteriorly, and the tendon comes anteriorly on the lateral side and attaches to fibula. This is the groove through which you see it goes anteriorly, and this tendon is intra-articular, so it's inside the capsule. And you can see the LCL ligament, lateral collateral or fibular collateral ligament is right on top of it, attaching from fibula to femur. Under that is popliteus tendon. So here is the popliteus tendon. Here is LCL, and of course, you don't see their resected other structures, so that you don't see biceps femoris right here. So let's go back here. So this is your popliteus tendon in short axis, long axis. Now, so if you have a patient with lateral knee pain, you don't want to forget this structure here, because you get these patients and you check their LCL and lateral meniscus, but you forget other structures. So popliteal tendon is again an important structure. You may see some tears, especially if someone is coming with traumatic history, some trauma, with varus stress on the lateral aspect of the knee. You want to check. Also pay attention to popliteus tendon, and everything is right there. You're not moving a whole lot. Everything's on the lateral aspect. Was that a little baby?
Okay. Yeah, it's my son.
Okay, so yeah, so check for LCL. Check for, let's go back. LCL. This is LCL, and I have another anatomy image coming soon, and I'll show you why you see LCL so wavy. So it may not be possible for you to check the entire to get the entire LCL in one view. So you can take multiple views, like I have taken it here. So, and I put overlap those images together, so you can see the entire attachment from fibula to femur. It may have, even with some varus stress, you may not stretch out it completely because of the other expansions on overlying it. So here is the LCL. You can see this band, and it changes its echo signal as you're going from proximal to distal, and that's because of its the way the fibers are arranged. You may see part of it hyperechoic, part of it hypoechoic. So you have to, if the integrity of LCL is in question, you have to always use dynamic evaluation or do varus stress testing. So LCL, again on the lateral side, and this is lateral meniscus, okay, meniscus. Popliteus tendon, don't forget that. So when you get LCL, you should always look for groove. You cannot miss this groove because it's there on the lateral side. But you've been looking at this groove for a long time. It's just that you were not paying attention to this popliteus tendon, which you should, especially if someone has lateral knee pain. Also, people with loose bodies, because this the sheath communicates with the joint, so you may see the loose bodies go around the popliteus tendon, and if it gets lodged there, that can be painful, and this tendon is important in locking and unlocking of the knee. So you can see that being a problem in people with arthritis and loose bodies. So check for this tendon. Now pay attention to this tendon. Okay, that's that. Okay, so yeah, look at this lateral aspect of the knee now. So that's the fibular head, right? Can you see the LCL right here?
Mm-hmm. Yes.
That's the lateral ligament. Overlying the LCL is biceps tendon. So biceps tendon does not have a clean single cord-like attachment there. It has an expansion, so you can see the fascia of the biceps and the biceps attaching to fibula, but it's superficial to LCL. And see, this is the reason why we do 30-degree flexion, because you want to move the biceps away. If you check for LCL and extension, you will have biceps overlying it, and that will make it a little bit difficult to scan it. So you have to have some flexion, so you move the biceps posteriorly, and you can get this window. So this is the area where you have a little fall here from the fibular head. LCL, if you remember the first image, LCL from fibular head, it goes down towards the knee, and then you can see a straight alignment of the fiber, and again it curves as it attaches to femur. And crossing, you cannot see the popliteus tendon, but crossing from posterior to anterior lateral is popliteus tendon right here, crossing over here. And you can see that it's popliteus tendon is inside the capsule. So you can see the anterior lateral capsule here. So retinaculum and the fascia from the anterior lateral aspect also has attachments to LCL. And going a little bit more anterior to LCL, you can see IT band. So here is the IT band. They have removed it and retracted it. So this is like, like peeled back IT band here. But this is the Gerdy's tubercle where it attaches. So this IT band, actually, you can see this is like a banana peel. They lifted it, cut it, lifted it, and it's just like falling here. But this is where it attaches right here. So it goes like this towards the lateral thigh. So IT band is another structure that you can look for, especially if someone has a history like history of recent trauma resulting in lateral knee pain. The entire lateral complex needs to be evaluated. I mean, the structures that you can evaluate with ultrasound. You should check for IT band. You should check LCL, popliteus tendon, and biceps femoris tendon. If that's if you suspect that to be involved based on their history. So that's lateral aspect. So now let's look at the layers, different layers of lateral knee complex. So going from superficial to deep, the first layer is IT band, biceps and biceps fascia. So let's go back. Layer 1, IT band, which has been removed here, peeled back, biceps and biceps fascia. So this is the first layer. So right under the skin, subcutaneous tissue, these are the structures that you see. Okay, so when you're scanning, you look for biceps and IT band, and of course you have to have a little different placement to be on each structure. So you'll be a little posterior for the biceps tendon, and biceps tendon is easy to scan because you can palpate it so easy. You have to align your probe along the biceps tendon and then move towards the Gerdy's tubercle, and then check IT band. You don't need to check the fascia of biceps unless someone has some type of trauma and they have hemorrhage in that area, which means rupture of muscle or tendon. In that case, you can check the integrity of the biceps femoris. Now, another point to be noted here, if you're looking for LCL and your LCL looks nice and straight, attaching to the bone, like a straight line, most likely you're on ITB. So if you find LCL very nice and easy and just a straight hyperechoic compact band attaching to a bony, relatively flat bone surface, it's just too good to be true, and that means you're on IT band. So Gerdy's tubercle and fibular head are not too far away, and if you have done knee scanning, you just have to move a tiny bit anterior and you're on the Gerdy's tubercle. And some people have like really prominent Gerdy's tubercle, and that can be confused with fibular head. Actually, that's one of the confusion in nerve conduction studies. So people try to look for fibular nerve or peroneal nerve around the Gerdy's tubercle, and they don't get any response. And that's because Gerdy's tubercle can be prominent and can be confused with fibular head. So you may not be on this bony prominence, but this bony prominence, and this structure is going to look nice and compact fibular structure. And remember, go here. So this is fibula and this is tibia. So LCL is supposed to go like this. If you see something that looks like this flat bony surface and you see a thin band going proximal, that is IT band. So this is the Gerdy's tubercle, and IT band goes right above this area. And this image is easy, you can see everything going, but when everything is overlapping and you can see so many structures are overlying in this area, these fascias can be confused with the other structures. So yeah, just pay close attention. If you find it as a compact linear thin band, just check one, make sure that you're not on the fibular head, sorry, not on the Gerdy's tubercle and on the fibular head. Okay, so layer 1, IT band, biceps and fascia. Then layer 2 is patellar retinaculum or patellofemoral ligament. So retinaculum is the lateral retinaculum and the fascia and patellofemoral ligament. So that's deeper to the IT band and biceps fascia. And between these two layers is your common peroneal nerve. These two. And we normally don't look for that on the lateral knee, but if you're looking for, like, different planes, as you follow sciatic to common peroneal, you're looking between layer 1 and 2. Now the last one, this deeper layer, is again divided into superficial and deep. So superficial is LCL and fibular ligament if a fibula or accessory bone is present on the lateral side. So LCL comes as a under the third layer, lateral ligament, and deep to LCL is popliteus tendon, which is inside the capsule, right? So this is where you have arcuate ligament, popliteofibular ligament. So these are the deeper ligaments which also blend with the capsular layers. And if you've done lateral scan, you have noticed a small tiny blood vessel right overlying the, we don't see it right here, but I'm sure you have seen a little blood vessel right overlying the meniscus here. So those are the genicular arteries, and so those are the lateral geniculate arteries which are run between superficial and deep structures. So these are your layers, and this is how it's arranged. So this is the, yeah, someone's asking a question.
Yes. Hi, Mohini. This is Ganesh. Is there a different name for fibular ligament? I never heard of that.
Yeah, so, like this is from the American Academy of Orthopedic Surgeons. That's the reference for that, the layers. So this is present only when this is accessory bone is present. So let me get the lateral knee again. Oh, here. So see, this is femur, right? And this is tibia, and that's the fibula. So over this condyle, lateral condyle, sometimes there's a small bone. So it's called fabula because it's not patella, but it's like a small, like sesamoid type of bone, like sometimes it's cartilaginous and not completely ossified. There can be a small ossified bone here, and that can have a ligament attached to fibula. So this is only true when this accessory bone is present.
Oh, okay.
Here, right here. Yeah, so this is the posterior aspect of the lateral condyle. So it is present somewhere like right here. And then from there to fibula, it has a ligament attached.
Okay.
So yeah, that's only when you have this accessory bone there on the posterior aspect. We did see a couple of these in module 2B sometimes. So some of the participants had that. So there are so many anomalies. There are more anomalies that we know. So that's why it's very important to clinically correlate your findings. So if someone has a medial and anterior knee pain, and if you found a little bone there, you will think about anomaly before anything abnormal. And then you can always utilize your sonopalpation. You can do dynamic assessment and see if this is something of concern. Yeah. So, and you may sometimes you may even run into an anomaly which is not even known in literature. You never know. Yeah. Okay. So let's move to the next one. So this is this image shows all the layers. So first one is your biceps tendon. This is biceps tendon, iliotibial band. So this is actually, they are connected with fascial band. So this is IT band. This is biceps tendon with his biceps fascia. Then you have LCL, and this is popliteus tendon. So popliteus tendon is in layer 3. This is layer 2, and this is layer 1. So tendon, ligament, and popliteus tendon. Biceps tendon, LCL, popliteus tendon. Layer 1, layer 1, layer 2, and layer 3. Okay. So superficial to deep, this is how you see them. Any questions so far?
Now, your common perineal is going to be hyperechoic in that region. Is that right?
Which one?
The perineal nerve.
Yeah, peroneal nerve hyperechoic, yes. But it has the starry night pattern there. So yeah, on that'll be on the lateral. Yeah, this is the common peroneal nerve here, which comes from posterior aspect, wraps around the fibular neck, and then branches into superficial and deep. Yeah, that's hyperechoic. Yeah, hyperechoic flattened structure. Okay, now you can do the grading for the lateral complex injury or LCL injury or LCL tear. If someone has traumatic history, they have varus type of stress, and you suspect that they have LCL tear, or it can be a combination, maybe lateral complex is torn. You can do the gapping or varus stress testing. So you're looking for the joint opening and compare it with the contralateral side. So so measure the distance at rest, and then do the varus stress, and then measure the distance again. Do the same thing on the contralateral side. If that difference is between the range of this, that's grade 1. Grade 2 is when that difference is between 6 to 10 millimeter, and grade 3 is more than 10 millimeters. So you can quantify that based on your dynamic assessment, right? This is also in this slide. You can also find in the pathology slide from the module 2B. Now, this is quantification of that opening or joint gapping. Now, qualitatively, you can look at the LCL or, for that matter, MCL or other ligaments, and you can grade them based on what you see in the ligament. So grade 1 will be so the ligament will be hypoechoic, but will be intact. So you will not see so much of joint gapping. So this is more like a strain where there is some microfailure within the ligament, but it's grossly intact. Grade 2 is where you see partial failure. So you will see some retracted fibers, and some of you have seen MCL grade 2. Many of you have actually. So grade 2 is clear. You can see some retracted fibers, but there's no complete retraction or complete disruption of the ligament. Grade 3 is complete disruption, so there is no continuity. So grade 3 is no continuity, complete disruption and retraction. Grade 2 when you see partial tears, so some part of it is intact, some part of it is not intact, and those fibers are retracted. Grade 2 is just the ligament is hypoechoic and swollen, but it's intact, so you don't see any fibers which have retracted. So any questions on this?
Oh,
No.
Okay, all right. So I am assuming it's all clear, right? Okay, so now let's. And no questions so far on anything
Nope.
that I presented. Okay, good. So now next I'm going to present a recently published study in Journal of Ultrasound and Medicine. Actually, a great study. Validity of indirect ultrasound findings in acute ACL ruptures. Now we know that ultrasound is not the first choice for ACL or PCL or intra-articular structures because we don't get the entire, we don't get the visualization, enough visualization. But there are some indirect signs that you can pick up with ultrasound. So there are 3 signs that you can pick up. So if you suspect someone has a recent trauma which is suggestive of ACL tear or rupture, you can pick up these signs. So 3 indirect signs. First is femoral notch sign. The second one is PCL, posterior collateral ligament wave sign or thickened PCL, and capsular protrusion sign. Now let's look at these 3 signs, how they appear as. So first one, femoral notch sign. So you're on the posterior aspect of the knee, and this is medial femoral condyle, this is lateral femoral condyle, and you have overlying medial and lateral gastrocnemius. So this is how your normal knee looks like in short axis. When you look at when you're at the femoral condyle level, you see the condyle and musculature, some cartilage line surface. When there is ACL tear or rupture, you will see this femoral notch sign. So there will be a little pocket of fluid, which is basically a hematoma here, because this is where the posterior attachment of ACL is on the lateral femoral condyles. So look for this pouch or a notch sign on the lateral condyle sign. This is the MRI image, and you can see the notch sign here too. We can see the same thing on the ultrasound. So that's number one, femoral notch sign. So everyone understand what this view is. This is a short axis view of the popliteal fossa, right?
Yes.
Is this clear?
Yes.
And left is normal, the right is abnormal. So here you don't see any pocket. Here you see a little, and this is on the interior side of the condyle, where there, on the not on the superficial aspect. So if you have something here, right, on the medial side somewhere here, that's Baker's cyst. Okay. Remember, posterior medial side, that's where the Baker's cyst presents between the tendon of semitendinosus and semimembranosus.
Correct.
So membranosus and tendinosus is here. It's not in the view on the medial side. So the notch or the neck of the cyst appears from here, and this is where you see the balloon-like cystic distension. So we are not looking superficial over the rounded part of the condyle. We're looking at this notch sign deep on the lateral aspect, on the lateral condyle, on the inner aspect of the lateral condyle. Okay, so that's femoral notch sign. Second, PCL wave sign. So again on the posterior aspect, but this time you are long axis on the posterior aspect of the knee. Now this is proximal, this is distal, so this is femoral condyle, this is tibia. Okay, this is long axis now. So femoral condyle, tibia. You can see a little bit of PCL from posteriorly. And so you do get to see a little bit of PCL, but you don't see the entire PCL here. But if you compare the normal side, this is the normal, okay, this is PCL. Compare that with the abnormal side. Can you see a little wave here?
Yeah.
It's a little wavy. And it's also thickened, okay? Now, ACL and PCL are inside, intra-articular, right? This echogenic line that you see here, where you see the arrowheads, that's the capsule, right? On the posterior aspect, capsule is more like a linear or a concave, has a concave or linear shape. Can you see the protrusion of this capsule?
Absolutely.
Yes.
Yeah. So that capsule is hyperechoic, ligament is hypoechoic. Okay. So here is normal capsule, normal PCL. Contralateral abnormal side, there is protrusion of this capsule and there is thickening and wave-like pattern of the PCL. So that's the second sign. Now the third sign, one more image of the, we presented both the signs together, PCL wave sign and capsular protrusion. More images of PCL wave sign or thickened PCL and capsular protrusion. So another case, normal on the left, abnormal on the right. So this is normal, you can see almost linear capsule posteriorly. This is PCL. So arrows are pointing at PCL, arrowheads pointing at the capsule posteriorly. Look at on the abnormal side, PCL thickened compared to the contra. This is the same patient, these two. This is PCL thickened, capsule distended, protruded posteriorly. So it has a convex shape. Again, normal. This one is subtle. This case is subtle. You can see again, almost like linear shape or flat posterior capsule. That's the PCL. Now look at this PCL and look at the protrusion here. So this one is subtle, but you can still see the difference side to side. And of course, you clinically correlate this. So 3 signs: femoral notch sign, PCL wave sign or thickened sign, so wavy PCL or thicker PCL, capsular protrusion sign. This is for femoral notch, your short axis, and for the other 2 signs, your long axis. Okay, so this is long axis. That the previous one was short axis. This notch sign should not be confused with anything else. So see, the blood vessels are on top. This is popliteal artery, PA. That's way superior. This one is deep. This is the capsule. This is inside the capsule here.
Mohini,
Yes.
are these specific to like grade 2 or grade 3 tears or?
No, they're just indirect. So let me show that conclusion so you'll understand. So, this patient will still need MRI.
Of course.
You will not miss any ACL injuries, especially young people who need repair. So this is their conclusion. Ultrasound does not and cannot replace MRI, but can help clinicians decide on further diagnostic tests and treatment in patients with acute knee injuries. These ultrasound signs are easy to determine non-invasively, especially in cases in which the clinical examination is difficult or equivocal. Ultrasound may help decrease the number of undetected ACL injuries and can spare patient unnecessary treatment for presumed diagnosis of a knee contusion, sprain, or strain. In addition, point-of-care ultrasound is cost-effective compared to MRI and can potentially give patient a diagnosis the same day while avoiding unnecessary anxiety and worry. So this is for those acute injuries, and you're trying to determine. On field these days, sports medicine doctors, they have ultrasound with them, and if someone injured their knee, and especially in acute injury, there is so much of edema and swelling. Your clinical examination is sometimes inconclusive. You don't know. You may not have a clear-cut anterior drawer test because there's so much. The knee swells up. There is swelling. So, and I think Brian, I think you had a case where someone sent you for ultrasound because they couldn't determine ligament. I think it was LCL injury because of the edema, and you did ultrasound, if I remember correctly.
Yes.
It happened maybe more than maybe 2 years back, or at least a year back. So especially cases like that, when there's a lot of swelling, your physical examination, clinical examination may not be clear, or you may still have doubt whether to send this patient back to play or to have them, get further examination. So if you pick these indirect signs, you can save that patient any further worsening of their injury. So it doesn't mean that we are actually grading ACL and PCL ACL tears, but we are picking up those injuries early on.
No, I guess my question was, so this would have to be, I think first off, I think the clearest for me personally would be the first one. The femoral notch sign looked like it would be the easiest for me to detect until I've done just repetitive looks at some of the wave sign and some of the thickening of the PCL. But will this be present in grade 2s or grade 3s, like a partial tear? You'll start to see some of this femoral notch sign even in a partial thickness tear? Is it hard to say?
No, in partial, so it's sometimes you have grade 1 where it's just like a little stretching. I think you don't, but grade 2 and grade 3 it would show.
Okay.
Yeah.
No, that's great.
I can read this in detail again, and I'll tell you what were their inclusion criteria. But I can see grade 2 and grade 3 because they create a lot of effusion and hematoma. So this is what you're seeing here: localized collection of hematoma, bleeding inside. So that's what this notch sign is. So I think grade 1 will not produce it. So 2 and 3 can produce it.
Okay. This is so valuable. Thank you so much.
Oh, sure, you're welcome. So this one is easy to pick. Even the second one, when you do ultrasound of the knee, even if you're not doing it for you don't have suspicion of ACL, when you're evaluating posterior knee, you should pay attention to this. That's how you get used to it. So you're doing your regular knee, maybe for anterior, medial, and lateral, but it's good to get into practice to just visualize the PCL. You have to increase the depth. Make sure you're using enough depth to look at the deepest part of the soft tissue posteriorly. You see the tibia, you see the femur, and you will see a hypoechoic band going down, and that's PCL. So you want to keep practicing it. You don't want to wait for that one case that comes in maybe 3 months, and now you're trying to look for this notch sign or PCL wave sign. So look for these structures on a regular scan. Okay, so that's that. All right. Any questions so far on this study, ACL indirect sign?
Mohini, this one would be one that would be super important to scan bilaterally.
Yeah, side-to-side comparison, yeah. Yeah, you want to do that, especially for the second and third signs, which is PCL wave and capsular protrusion. As you can see here, the difference is subtle in this case. Like,
Yeah.
this more obvious here, and the previous one, this one, but it's subtle on in the last case. So yeah, I would say side to side is important.
What other pathology can also produce capsular protrusion sign?
I think joint effusion can do that.
Joint effusion.
But yeah, it's basically, extra, there's more, the volume has increased, so it's pushing the capsular tissue posteriorly. Yeah, so that, yeah, if someone has like overall increased fluid in the knee, then you don't want to say it one of the indirect signs. You have to have,
You have to have all three?
and also clinical correlation. Like if someone has a gradual onset of pain of knee for like 7-8 months, and you're looking at arthritis and loose bodies and no meniscus, and you see some protrusion here, I wouldn't call that ACL indirect sign. I would just report it as findings, because there is no clinical correlation here. You always want to make your ultrasound exam and report as tailor-made to the patient that presents. It has to be tailor-made to that patient. You don't want to just have a standard protocol. Okay, I have to check. So this, and you list of 10 structures on everyone, because one patient may have more symptoms on the medial or posterior or anterior. So it has to be tailor-made to that patient and the question that you're answering. Okay, all right. Okay, so next study, and this one, Brian presented a very good case last year, Brian Cochran, and you will find this interesting because it's a good study on, again, Journal of Ultrasound in Medicine. So their report is a review and review article with some very good insights into calcific tendinopathy. So if you remember from mentorship and fellowship module, we talked about calcific tendinitis, and there are 3 distinct stages. I think because Brian presented a case, he probably remembers from last year. There are 3 stages of this calcium buildup. So calcium buildup in the tendon is known as calcific tendinitis or calcific tendinopathy or tendinosis, or you can call it hydroxyapatite deposition disease or CPEPD. There are 3 stages. They are known as precalcific or formative. That means the calcium, the molecular environment is changing inside the soft tissue. There are fibrocartilaginous metaplasia with decreased oxygen tension, which basically sets in the molecular environment for that calcium to form. So this is the first stage, precalcific, followed by calcific stage, which is when the calcium builds up and becomes a well-defined mass in the tissue, tendon more specifically. So it's known by resting phase or calcific phase. The last one is post-calcific phase or resorptive phase. This is the phase where there is cellular reaction around the calcium buildup. So that calcific mass shows more vascularity around it. So you will see the hypoechoic tendon, and there's a mass in the tendon. The size of it grows. Why it grows? Because it's now trying to get resorbed. So it becomes diffuse. So it becomes poorly defined, and it may migrate to neighboring tissues. Like it can go proximally to the tendon, or it can go to other adjacent structures. So this is the stage where patients complain of pain. So you may find calcific deposit in patients as an incidental finding when they are in these 2 stages. This is the stage when they complain of pain and severe limitation of movement. And within this 3rd stage, which is post-calcific, the stage, there's a specific period when they complain of severe pain and limitation of movement. That's when this calcium is trying to migrate or move into adjacent tissue. And the good news is that this pain gradually disappears in 2 to 3 weeks, and they may need some aggressive symptomatic relief for that time, but the good news is that most of the time it disappears. Rarely or when cases need some intervention to get rid of that. So this is the stage which is problematic, and which is when patients are more symptomatic. Now, so this is how the migration happens. This is the calcific migration, and this is the, here you can see the reference if you want to look at this study. So this is tendon, and that's the muscle, and this is bone. And so this is calcium deposit here in the tendon. Then in this image, you're looking at the calcium being migrated along the fibers. So instead of becoming in, as a solid block in one area, you will see it dispersing or moving to proximal part of the tendon. It can move further proximal into the muscle tissue. It can go to the bone, go into the bone as a lytic lesion, or it can go into the overlying tissue like bursa. In case of supraspinatus, it can go into migrate into the bursa. And sorry, this one is migrating into the bursa. This one is in between tendon and the bursal plane. So this is quite painful, because as you're moving, subacromial space gets narrowed because of this extra thing occupying space there. And anyway, when there is resorption, there is a lot of vascularity in the tendon, so the tendon is more symptomatic in this area. So this is the stage where patients are more symptomatic. So, and here are some examples. So here is the calcific mass, and you can see it's migrating proximally. It's migrating towards the bone, right? So this is the migration into the bone, into the tendon, and you can see this area is not as dense as this one, but this looks like a more amorphous because your body is trying to absorb it. So there's migration of this calcium deposit proximally into the supraspinatus fibers and then deep into the bone here. In this example, again, it doesn't look like very nicely well-defined solid bone. This calcium deposit is more dispersed here. Now it depends. So pre-calcific, early phases of calcific and post-calcific can resemble, because we don't know if this is when it's starting to form or this is the one that's getting resolved. But you can always correlate with patient symptoms. If this is the symptomatic stage, most likely the patient is in post-calcific stage here, where there are changes in the tendon. The tendon is more vascular. If you look at this tendon arthroscopically, then the tendon will be red. It'll be inflamed and swollen. And this mass is growing in size, but not in density. It's not as dense, but it's growing in size. Now, look at this mass. Actually, let me go back and focus on one more thing here. So these are the three stages here: pre-calcific, calcific, post-calcific. Like I said, the post-calcific or resorptive phase is the stage when patient is symptomatic. In this stage, when you just have a little calcium block, usually patients are not symptomatic, but this stage can cause mechanical symptoms. What do we mean by mechanical symptoms? That means that calcific mass, which is like a solid structure, can impinge on on other bone or other structures and can cause mechanical symptoms. So the calcium there in the tissue is not symptomatic, but that calcium hitting other structures can cause symptoms. That's what we mean mechanical. So patient can still be symptomatic in this stage here. So that's so this is post-calcific. Now we are at calcific stage or formative stage where there's calcium deposit. This is a solid calcium mass because you see an artifact. And what is that artifact?
Posterior shadowing.
Okay, I hope you didn't see here, right? The red one, although this is so obvious. You see the posterior shadowing, right? So we know this is a solid mass. It's blocking the ultrasound, so you don't see the structures underneath that. So this is subscapularis, and this is a big calcific mass here. You can see long axis of subscapularis. This is the short axis at the level of the bone here, right? So you can take one short axis where you will only look at the tendon overlying the bone, and you can take one short axis where you will see this bony growth or bony deposit here or calcific deposit here, right? So it matters where your short axis view is. So let's say you have this view of subscap. You see the deposit, you see the tendon, but your second plane of view in short axis of this tendon, you did not take it here. It's very important that you have a short axis here to confirm this. Remember the first slide? You have to, yeah. This is calcific, but this can cause mechanical symptoms. How? When patient is doing internal rotations, this solid mass can hit against the coracoid process. Remember, when we scan subscap, we have the patient do external rotation because we have to expose the subscap for scanning. But if there is a big chunk of bone sitting in the tendon distal aspect and you have the patient do internal external rotation, they can get mechanical symptoms of pain because of this calcium block rubbing against the coracoid, subcoracoid space. So this will be one of the examples of that calcific stage being symptomatic because of mechanical symptoms. Make sense?
Yeah.
Yes.
Okay, good. All right, so that's calcific tendinopathy or calcific tendinitis. Any questions on that so far?
So Mohini, the image on the right, so that means the patient has multiple calcific process in that tendon, within that tendon, or?
So, yeah, so it's a calcium deposit, but it may not be a nice and smooth deposit. It can have some irregularity. But yeah, you do see different surfaces here within that mass. So it's possible that some areas are less calcified, like there's less deposit than others. But you can see all of them are causing posterior shadowing to a certain extent, right? So
Yes.
it doesn't follow a specific shape. Calcium deposit can be irregular. It can be it may not have a nice flat smooth surface. It can be irregular.
What about the circular structure proximal to that on the left side of the image?
You're talking about short axis?
Yeah, yes, short axis, right there.
So the structure proximal to it?
Right here. I don't know whether you can see the mouse.
No, we cannot see clearly here. But yeah, overlying at this level, this is a deltoid, and then this is subscap. But because of shadowing, you cannot see it clearly. So I don't think this is a good view to look at the proximal structure. If I move my floor a little bit more proximal, I can probably see the structures.
Okay.
Yeah, you can see some structures there like supraspinatus.
Thank you.
Okay, so that's that. All right, let's move next. Okay, so now back to the knee. So this is patellar tendon. Okay, proximal left, distal right, cephalad, caudal, patellar tendon, patellar tendon. This is patella, and this is tibial tuberosity. Now, tell me if there is anything wrong here. How does this image look to you?
It looks like it's on a slack rather than a stretch.
Okay, but the tendon looks uniform.
Looks good to me.
Yeah.
Yeah.
Tendon is uniform. Yeah, there is some slack. That's right. But the tendon is uniform in thickness. No focal thickening, proximal or distal. More uniform thickness. There is some fibrillar pattern, and of course this dark areas because of anisotropy. So the tendon is okay, right?
Right.
The bone looks smooth. Right? Nothing superficial to the tendon. Subcutaneous tissue, skin looks okay. How about deep to the tendon?
Looks like edema.
Which area? Distal or proximal?
Distal.
And you, why do you say that? Because you see a hypoechoic structure here?
Yeah.
Oh, sorry. Anyone else?
Still, it's okay to me. I don't really see much in that one.
You don't see. Oh, baby tried to say something. Okay, so this is, so there is a hypoechoic signal here, but this is normal. Fat pads can be confusing because they have heterogeneous appearance. So fat pad, whether it's knee or ankle or anywhere else, fat pad is made up of fatty and fibrous tissue, and the composition can change from place to place. So especially between the tendon and the bone here, sometimes a big fascicle of fatty tissue, a big lobule can appear hypoechoic. Should not be confused with bursitis or bursal effusion or edema. Because fat pad can have heterogeneous appearance. So this is a big fascicle where there's more fat concentrated, and so that's normal. Why that's normal? Another thing is I'm also looking at artifact. If there was a fluid here, I would see an artifact behind under that, and what that artifact would be posterior what?
Posterior enhancement.
Enhancement.
You'll see enhancement. We don't see enhancement here. The bone looks normal, almost the same here. No enhancement. Rest of the fat pad is okay. So that settles that there is no artifact underneath that darker area. And then if you're still not convinced, let's say this patient is symptomatic anteriorly. Now here you're really looking for something to blame. You're looking at structure to blame. Why this patient has anterior knee pain? The tendon looks good, the bone looks good. There's nothing superficial. There's nothing deep. But yeah, fat pad looks suspicious. There's this dark area without the posterior enhancement. Is it really something abnormal, or this is their normal anatomy? So what do you do? The next step?
Short.
Short axis, or second plane of view. Exactly. You take the second plane of view at this level. Not here, not here, not here, not here. Exactly at this level. And when we took this short axis view exactly at this level, we found this. This is patellar tendon. Here. This is fat pad, and this is the tibial bone.
Okay.
Nothing, right? Just looks like fat pad. The tendon looks normal, flattened, hyperechoic structure with some internal echoes, right? That's the patellar tendon in short axis, and this is the fat pad. So yeah, so you do the second view, and you can also put a color Doppler sign there. You can do little sonopalpation. If there's fluid, you can displace it with compression. If there is none, then you cannot move it away. But you can change it with your probe angle. Sometimes when you tilt it back and forth, it can change the signal. Now this is another patellar tendon. Here you see a hypoechoic. Now this is long axis, this is short axis. Is this abnormal or this is normal?
Abnormal.
This is abnormal. And why do we say that?
Effusion.
Because there is very clear localized anechoic signal between the tendon and the bone. And if you see the signal underneath this darker area versus here, there is some enhancement. Yeah, this is from a lower frequency probe, so it's not like a little grainy, but you can still see some enhancement underneath here. And when you do the short axis view, you can still see that local collection of fluid. And this is patellar tendon right here. This is patellar tendon. Right under the patellar tendon, exactly what you see right here, that shows up in the second plane of view. So that's deep infrapatellar bursal effusion. Okay. Yeah, so that's why we have to do a lot of normal scans to understand abnormal. Okay, so any questions so far on that?
So on the previous image, there was nothing wrong with it?
Yeah.
Okay, so there's no abnormality here.
Yeah. And also like this darker area, can you see within the darker some echo within it? So it's not completely like it's not a hypo or anechoic. It's hypo, but there are some hyperechoic diffuse region within it. Like inside this structure, you can see that, right?
Yes.
Yeah. So yeah, that's a fibrofatty tissue. Very good. All right. So last thing I wanted to emphasize this again, and I have presented this in the last webinar too. Rotator cuff. Make sure when you're scanning the tendon in long and short axis, this cuff is a continuous structure. So you have to scan the structure in long and short axis. If you're doing the long axis, you will have to go anterior and posterior on the entire cuff. So if you're supra, your long axis, don't just settle for the mid portion, go a little bit more anterior and posterior, infra, a little bit anterior, posterior. And when you do this scanning, when you move your probe in long axis, anterior and posterior, it's not a whole lot of movement. You're moving a little bit, but you have to scan the entire width of the tendon, supra, infra, teres minor if applicable, and subscap. It's a big attachment here, up to like 3 to 4 centimeter long. This is also about 3.8 to 4 centimeters. So the entire width of the tendon should be, or the cuff should be evaluated. So you don't want to miss any focal tears in posterior and anterior. And try to be consistent with your placement, because once you are consistent with that, you don't have to like pay too much attention, or was that anterior or posterior, if you follow the orientation, because structure like this can be a little confusing. So here again, they look at the footprint. It's 3.8 centimeter. Subscap length of this footprint anterior to posterior, proximal to distal is about 3 to 4 centimeters. The entire thing is 4 centimeters. And the attachment or the footprint can be 1 to 1.5 centimeters. So you have a little bit of area that you can cover in short and long axis. So you want to do that. Okay, now next thing again, when you're looking, because we are doing shoulder a lot more than other region, same thing applies here. Remember the 5 things that you're looking for in the beginning, the first slide. Echo signal, is the tendon hyperechoic, hyperechoic, or anechoic? What's the morphology? Is the tendon showing normal morphology, or if there is any changes in the shape of the tendon or internal architecture? Any focal defects or complete retraction? If there is tendinosis, you want to see the color Doppler, or if there is any hyperechoic signal around it, you want to see color Doppler information. And if there is any confusion, you can always do dynamic evaluation. You know, those thickened bursa that herniate into the space, you have to do a dynamic evaluation to tease out partial tear versus just tendinosis. And in rotator cuff tear, you can measure the degree of tear, you can measure the size. If it's tiny microfailures, that can be difficult to measure, but when you see a focal defect, nicely defined focal defect, you can put a caliper and measure that. And you can say that, okay, the fibers are retracted up to a centimeter, or a millimeter, wherever the measurement is. You may comment on the shape or muscle and tendon quality. So a quick example, this one, let's look at the normal tendon first. This will be the last slide. So this is normal supraspinatus, right? GT. This is GT.
Mm-hmm.
Head of humerus. That's supraspinatus tendon. Overlying supra, this hyperechoic interface is the bursa. No fluid in the bursa. This is deltoid, then subcutaneous tissue and skin. So skin, from top to down, skin, subcutaneous tissue, muscle, bursa, tendon. You can see some cartilage and bone, right? So this is how supraspinated tendon appears. So look at the echo texture, look at the morphology, the shape of the tendon, Look for the continuity if there are any focal defects. If we have a color Doppler, if this was a live skin, I would put a color Doppler here, and then dynamic assessment to make sure that there are no focal defects. Now let's look at this image. What do you see here? So number one, let's go by number one. So first is echo texture. What's the echo texture?
Disruption of the fibers.
So talk in terms of
Hypo.
echo, like, is it hypo, anechoic, hyper?
Oh,
Hypoechoic, right? There's a hypoechoic signal that we see in the tendon. Good. Second point, morphology. Now comment on the shape of the tendon. Does it have its normal shape?
no.
No.
No, right? So it has, there's loss of normal tendon contour or tendon shape, because it is supposed to be like this, like a bird beak, like a peacock beak, rounded, and then comes here. Can you see a little flattening here?
Yes.
Yes. Because of this loss of fiber here, there's a little flattening here. There's a drop of this to this way, right? So that because it has to drop down because there is nothing else intervening between the top layer and the layer underneath that. So okay, so echo texture, morphology, normal, the loss of normal morphology. Now number three, defects. Are there any defects that you see?
Oh, yeah.
Yes.
Yes.
Focal defect, you do see. So this is the one where you can put the calipers, right? Don't you agree? You can put the caliper here in this view and this view, and say approximately, how big is the defect and how much fibers have retracted. Okay, number four, color Doppler. I don't have a color Doppler image here, but I would put it and I'll say, okay, if there is any new angiogenesis or not. So you want to use color Doppler in every scan. Okay, especially whenever you see hypoechoic or anechoic signal. All right, the last point is dynamic. If it's necessary. So here everything is nice and clear, but you can see dynamic assessment to enhance this focal defect. And if not to enhance, let's say everything is, you want to do a subacromial improvement, dynamic assessment, and see if the tendon or the bursa is getting pinched. Sometimes you can see more pooling of fluid. Does a dynamic assessment. So it's possible that the fluid has been collected, right? Like if I extend this image further to the right, so this is GT, so this would be humerus, and deltoid is going like this. Between deltoid and GT, the fluid can be like a cystic distension here, right? And so it's possible that you're just so focused on supraspinatus that you didn't look for any bursal effusion. But if you do dynamic test, you can push that fluid back here, and so that's what gives you that extra information about impingement and what's getting impinged. So that's that. So all right, so that's good. So we covered all the points. So if you keep in mind what the echo texture is or echo signal you're looking at, what's the shape of the tendon, if the tendon has defect, and if there are any color Doppler sign and dynamic evaluation. Let's try to write an impression for this. So if someone wants to give a try, how would you write this up? Saying everything that we covered in those 5 points.
This is an abnormal study. It depends on how we're writing. If we're jumping right to the impression, or something along the lines of there is a focal cortical sided defect in the supraspinatus tendon. The tendon demonstrates loss of fibrillary pattern with a slight flattening at the cortical insertion. I think that's.
Yeah, no, so that's right. So I would, so this is flattening, but I would say there's loss of tendon contour, which you see in the template, loss of tendon contour. Because if you say this flattening on the cortical side, that can be a confusing terminology for someone who's reading it and doesn't know it, because all the fibers eventually, insert on the cortical side of the bone.
Okay.
So you just want to, like, simplify everything and just say that there is just loss of normal shape or normal
Tendon contour. Okay.
Yeah, and then because you're already defining where the stair is, you're already defining this by saying where the defect is. So you don't have to, because you have already defined this defect, you don't have to define the loss of the shape, the shape of the tendon now.
Okay.
Yeah. So yeah, that's good. And if you have any extra information from color Doppler ultrasound or dynamic assessment, you can add that. But yeah, I would say this is focal articular sided defect in the tendon, and there is loss of normal tendon contour. Very good. That was good.
Good job, Brian.
No, I don't know.
Okay, any questions? That's it. That's the last one.
You should write a book, Mohini.
All good. Okay. I'll see you next.
Now, Mohini, we talk about plating. Do you ever see, because we talked some also about deltoid herniation. Do you ever see a herniation of the supraspinatus tendon at all?
No, like you getting into the deltoid.
Yeah.
No, that wouldn't happen, because so if you think about it, any structure that herniates into another structure or another plane, usually it takes the path of least resistance, right? So it is a lot of effort for supra to herniate superiorly into deltoid, and even if there is some deltoid defect, let's say the defect is on the deltoid side and there's a hole, let's say there's a hole right here.
Mm-hmm.
That would fill up with hematoma and fluid, and that is still going to push it towards the supraspinatus. Gravity, positioning, if you think about like how the structures are arranged, and then gravity pulls the fluid towards the gravity dependent area, and that's the reason why when there is more effusion in general, where there's more fluid in the shoulder, the fluid tends to accumulate around long head of biceps tendon sheath, right? Even if you don't see a whole lot in the AC and in the shoulder joint, you will see even the minor effusion, you will see around the biceps tendon sheath first. That would be the first sign. That's because the gravity, that's a gravity dependent area, so it accumulates there. So unless there is, for some reason there's a rupture here and there's a lot of fluid and that fluid escapes and takes the space, but I don't think supra can herniate here.
Okay.
Fluid from bursa maybe.
Mm-hmm.
Yeah, but supra, I think highly unlikely.
Okay. Yeah, I just had one today that had just a little different shape to it, so I was curious.
Okay. Yeah, some people can have, if you have someone with the this inflammatory arthropathies, they have synovial tissue growing into different areas. There's condition like synovial proliferation, called vulinodular synovitis. That can present as something like that's a little overgrowth of the synovium, which is hyperechoic. Yeah, so the case.
Okay.
One of the examples.
Hey, Mohini,
Yes.
I have a question.
Yeah.
So you would want to say anything about that it's like partial thickness. You just always use the term loss of contour, tendon contour.
No, we do say partial there.
Okay, so
we always say partial. Yeah, I think we assume that it's a partial. No, it is a partial articular sided defect. Yeah, I think that's what Brian tried to say. Yeah, so he just said the important points in the impression. Yeah, of course, this is partial there.
Is it
okay,
or is it mild, moderate, kind of?
Moderate what?
Moderate tear, or do you say partial tear?
We don't quantify it exactly like MRI, but you can define it by location. Is it articular-sided, bursal-sided, mid-substance? You can definitely say it high grade if you see more than 50% of the tendon thickness is involved. Like if there's a significant portion of the tendon is torn and part of it is on the bursal side, part of it articular, sometimes you can have high grade complex. When you can see only few fibers, less than 50% of the fibers are intact, you can put them in that category, but usually with ultrasound, you just define it by its location.
And is there a cortical irregularity on this image, or you don't really see that?
Was that?
Cortical irregularity?
Yeah, there is cortical defect here.
Okay.
Yeah, right here, irregularity, yeah. So you can follow any guideline in quantification and stick with that. You can definitely quantify it. There's no harm. It's just that with ultrasound, there is the terminology or the grades which are widely accepted or universally accepted are by the location. Those are the most common grading that is used universally. So if someone else is reading your ultrasound and it's going somewhere, they understand that this is how you grade it on ultrasound. Okay, good questions. Any more questions?
Nope. I'm good.
Okay,
Thank you very much.
That's all for now.
Thank you,
all
Mohini.
right, good. Good night, everyone.
Good night.
Good night, Mohini. Thanks.
Good night.
Good night.
Good night.